Hey everybody! Today we're going to go through the biochemical lectures. So of course, we already went through anthropometrics. We're now on the B for biochem. Then we'll get to clinical and physical, dietary, environmental, and social. So why do we use biochemical analyses or blood data or biomarkers? Well, initially to help determine what's happening internally. And we can get a clearer picture of what's happening when they're utilized with other assessments. And other assessments means things like, oops, going too forward. Trying to get my pen. All right. So to present a clearer picture when utilized with other assessment data. So what are some other assessment data that we could be talking about? Well, it might be our anthropometrics and our clinical. Even the environment is important to consider. We also can look at blood and urine samples for these. So for proteins, nutrients, and metabolites that often reflect nutrition status. And the nice thing about biochemical markers is they can often detect a nutrient deficiency before anthropometrics because these biochemical markers are changing much faster than our body weight or height. And some, but certainly not all, I'm going to underline that, not all, reflect current nutrient intake. So plasma is probably the best known. And the plasma, as you see here, plasma is, after you spin down blood, it is the clearish looking liquid, but it still has the coagulation proteins present, these little stars. The serum is the fluid without the coagulation proteins, so no proteins. And in fact, you'll see all the clotted red blood cells in the bottom. And this matters what tube is used, which we won't get into, but it's good to know that you need a special tube to get serum versus plasma. So we can look at erythrocytes or red blood cells, leukocytes, white blood cells, and in fact, the white blood cells are right here in what's called a buffy layer. But we can also get non-blood tissues, muscle, liver, fat, urine, saliva, feces, sweat, and hair. So it's important to note that there are different types of blood assays. There are static measures. These are things that measure nutrient concentration. So concentration is something like how much of something, so maybe in grams, are there per a unit of volume, say milliliters. On the other hand, we have functional assays, and these have to measure a biochemical or physiological activity. So a nutrient needed for a process to occur or to function as a coenzyme. So this might be an enzyme itself or a coenzyme. An example is the thiamine assay. The thiamine assay is called erythrocyte transketolase activity coefficient. So think about thiamine. Thiamine is helping us generate NADPH. So we need to measure how active that process is. So we have two types of assays. The first is the static assay. This is measuring how much of a nutrient is in a concentration. So it might be something like grams per milliliter, some amount by some volume. And we can do this for especially minerals, things like iron, zinc, retinol, and folate, although serum zinc is not a good indicator of zinc nutrient deficiency. On the other hand, we also have functional assays, and these are going to measure the biochemical or physiological activity. So a nutrient might be needed for a process to occur, aka an enzyme, or to function as a coenzyme. An example is thiamine transketolase activity coefficient. Oops, sorry about that. So, as I'm sure everyone remembers, thiamine is needed for the this enzyme, which is transketolase. In fact, thiamine is a coenzyme. So transketolase will only work with thiamine. So we need to be able to detect if transketolase is working, and that means we have enough thiamine. Similarly, riboflavin. The enzyme glutathione, which is a reductase, requires riboflavin. So we need to measure the glutathione activity to see if we have enough riboflavin. And finally, we can also measure the urinary excretion of certain products, say xanthorenic acid, in response to tryptophan consumption, and that will allow us to determine something like B6 status. So all of these are functional assays because we have to see if something is working versus just the concentration. So this is a brief table just outlining different laboratory tests, the acceptable range, and then a description, so why we use it. So red blood cell count, important for anemias. Hemoglobin, important for anemias. Hematocrit, important for anemias. Mean corpuscular volume, also important for anemias. Mean corpuscular hemoglobin concentration, also helpful for anemia. And then white blood cells will tell us about immunity. And here we have our serum proteins, and we're going to get much more into this. Electrolytes and others, like glucose, HbA1c, blood urea nitrogen, etc. So first, let's talk about the metabolic panel. So the basic metabolic panel includes glucose, calcium, sodium, potassium, carbon dioxide, chloride, blood urinary nitrogen, and creatinine. Sorry. On the other hand, the comprehensive panel includes all of these. Oops, sorry. When I'm using my hand, sometimes it accidentally zooms in. Includes all of these plus albumin, total protein, ALP, ALT, AST, and bilirubin. There's also lots of other panels, but they vary by hospital and lab. So this is the basic urine analysis. We can detect things like glucose, ketones, blood, bilirubin, urobilirubin, and leukocytes, as well as the specific gravity, pH, and protein content. From other specimen types like saliva, we can determine cortisol concentration. From feces, we can look at fecal fat and some vitamins and minerals. We can also check for blood. This is an important one for colorectal cancer screening. And sometimes this can also be an indicator for ulcer, blood loss, which may present as an anemia. We can also measure sweat for chloride or sodium, like cystic fibrosis. Famously, cystic fibrosis means that you have a lot of sodium on your skin. So back in the day, midwives used to actually lick babies, and if a baby was salty, they knew that it had cystic fibrosis. Well, they didn't know that it had cystic fibrosis specifically, but they knew that something was very wrong with it and that child wasn't going to survive. But now we have good treatments for cystic fibrosis. Hair is nice because we can detect zinc, selenium, other trace minerals, as well as cortisol. And hair also gives us a time period from a single sample. Because as hair grows, it's reflective of the status over many months, and it's not influenced by diurnal variations or short-term fluctuations. And that's especially important for cortisol, which has a strong diurnal secretion. Unfortunately, it is susceptible to contamination from exogenous sources like dust, water, cosmetics, uh, hair dye, as well as color, age, and pregnancy. So anti-dandruff shampoos, which contain selenium, would artificially increase that. Those are like Head and Shoulders. Red hair tends to be higher in certain minerals, zinc, iron, nickel, and copper. And we see higher iron and magnesium, or manganese, in brown versus blonde hair. All right, now that we have a general overview, let's look at our indicators of protein status. So we have somatic and visceral protein stores. And these contain metabolically active protein, or body cell mass, that can be drawn on to support body functions. So first, think about all of the ways that we have to use protein. We need it, obviously, for muscle mass. Oops, still have the eraser on. But probably more importantly, we need it for enzymes, as well as a variety of other things. So our somatic way of detecting protein stores, or the body protein, like muscles, we can look at a person's weight, skin fold thickness, creatinine production, total body potassium, nitrogen, use DEXA, CT, MR. We also have visceral proteins. These are more of our serum proteins. So our total protein, albumin, transferrin, binding proteins, prealbumin, IGF-1, insulin, IGF-1, as well as our protein hormones, which is why I said insulin. So we need dietary protein to go in, and we can measure dietary protein. And we excrete nitrogen, so we can also measure the nitrogen output. Together, the somatic and visceral protein stores comprise 30 to 50% of total body protein stores. Protein energy malnutrition isn't typically a problem in the US, but it can be in impoverished households, in hospitalized or ill patients, and, well, it's basically patients in general. So, how can we measure somatic protein stores? We can use mid-arm muscle circumference, or muscle area, excuse me, as well as mid-arm circumference. We can just look at body weight, or we can use a diagnostic tool like the PGSGA, and we'll talk about that more in the clinical section. We can also look at biochemical tests. So the creatinine height index, 3-methylhistidine, and specific serum proteins. So, as you probably noticed, the word creatinine is very close to creatine, and in fact, the two are related. So creatinine is the only metabolite of creatine. And so here we have, we have creatine. It gets transformed into phosphocreatine, and from there it becomes creatinine, which is a waste product present in all body fluids, filtered through the glomerulus, and excreted in urine. And the amount of creatinine depends on muscle mass. So 98% of the body creatine is found in the muscle. Creatine spontaneously dehydrates to form creatinine. So this process is spontaneous dehydration. And so a measurement of creatinine in a 24-hour urine collection should reflect total body creatinine and therefore total muscle mass. So we can use the creatinine excreted in urine over a 24-hour period and assume that it's proportional to muscle mass. But we have to ask our participants or patients to have a meat-restricted diet. The creatinine index is really a measure of muscle turnover. But the problem is that dietary or supplemental creatine, which like everybody, I feel like, especially a lot of dudes, take, it can be different on physical activity. So this might increase turnover. Trauma will increase turnover, as will sepsis, and the phase of the menstrual cycle. The older assessment, which is the creatinine height index, or CHI, is still available but not used as much, but it is expressed as percent of expected. The problem, though, height is not a good index of muscle mass. But we do find that the CHI is correlated with MAC. So here, we're looking at urinary creatinine and the creatinine height, or creatine height index. So we have this equation that for every kilogram of skeletal muscle mass, the amount of urinary creatinine plus 4.1 and then times 4.1 will give us the kilograms of muscle mass. But this hasn't been tested in malnourished patients. who are at the highest risk of being protein energy malnourished, and we don't have standards. This is just for interest. We can also look at 3-methylhistidine excretion. Um, this is a modification of the histidine residue of actin and myosin after synthesis. So think power stroke. So this is released during normal muscle turnover, and it can't be recycled. So it has to be excreted. So therefore, the excretion is related to muscle mass. It's not a common lab assessment, and it's predominantly used in research. So an example of a visceral protein imbalance is kwashiorkor, or this is known as the sickness that the baby gets when the new baby comes. And this is often because in developing countries, when you become pregnant, even if you have a new baby, you tend to lose your milk production. So the first baby starts to get sick when the new baby comes. Or the disease of the dispossessed child. I think every oldest sibling loves to be thought of as the dispossessed child. And kwashiorkor is really seen as low levels of albumin. Please remember what albumin is from Zoo 3115, especially osmotic balance. So if albumin is intravascularly depleted, think about we have a nice blood vessel, and recall that albumin is quite large, so it takes up almost the whole vessel. So the concentration of albumin is greater inside the blood vessel, so H2O is going to go into the blood vessel to balance the concentration gradient. On the other hand, if we lack albumin, so now we only have one little albumin, the concentration for H2O isn't different. Or it can even be that bad that H2O actually exits because the concentration of solutes is greater outside the blood vessel. And that's going to lead to something like edema. It also will increase antidiuretic hormone, also known as vasopressin, and lead to hypovolemia, because we're going to try to retain as much water as we can. Additionally, plasminorenin also corresponds, causing sodium retention. So even though the kwashiorkor is a disease of albumin depletion and not getting enough protein, it will lead to things like hypovolemia, sodium retention, and edema. So here's the highlighted area where we have albumin, transferrin, and prealbumin. So now let's talk about two different types of proteins. We have acute phase proteins. And acute here means fast acting or fast changing. But let's just think about it as fast phase proteins. And these are proteins that can change their serum concentration by 25% in response to inflammatory cytokines. That's a lot. That's a quarter. Acute phase proteins are part of our innate immune system, and they mediate systemic effects of fever, leukocytes, increased cortisol, decreased thyroxine, decreased serum iron, and many others. So if a protein is a positive acute phase protein, that means the concentration increases. So positive, it doesn't mean it's good or bad, it means it's increasing. We also have negative acute phase proteins, which doesn't mean they're bad, it means they're decreasing. And the increased production of positive acute phase proteins is a sensitive indicator of inflammation. So, serum protein evaluation, looking at our visceral protein stores. It is reflective of nitrogen balance, but it can be affected by hydration status, pregnancy, kidney function, some medications, stress, and more. Uh, Negative acute phase proteins, so these are ones that decrease, are albumin, transferrin, transthyretin, also known as prealbumin, and retinol binding protein. So these are decreasing. On the other hand, our positive acute phase proteins are C-reactive protein, orozomucoid, fibrogen, heptoglobin, and then an A1 glycoprotein. So these are increasing. So let's start with albumin. Albumin is abundant and stable in the serum. Albumin is the workhorse protein. It provides osmotic balance, and it carries everything. It's also easy to purify, and around 60% of total protein, serum protein, is albumin. So this is a highly used measure, which is a good prognostic screening tool, but is not a good measure for nutrition monitoring. So the shortcomings of albumin for protein energy malnutrition assessment is primarily that it has a longish half-life. So it takes 20 days to change. So you'll have to be in protein energy imbalance for 20 days before you see a change in albumin. It's a negative response protein. So you have to assume that it was adequate at some point before your measurement, unless you have a measurement over time and you are seeing it decrease. We also have a very large extravascular pool that can be recruited. Therefore, it can return to circulation and buffer loss. And sometimes it's infused in hospital patients. So our next one is transferrin. You probably have known about this one for iron transport. And it's controlled by the iron storage pool. It's correlated with clinical outcomes in children with kwashiorkor and marasmus, but it doesn't work great for protein energy malnutrition. Again, because it's a negative response protein, it has a slightly faster, or not slightly, it has a considerably faster half-life, 8 days versus 20, but it's non-specific. It can be high when iron stores are low. It can also increase with estrogen therapy. So next up, we have transthyretin, which you might have heard be called prealbumin. It was called prealbumin because back in the day, it ran faster on gel electrophoresis than albumin. So not that it is actually before albumin, it just is faster. So transthyretin binds retinol binding protein, and thyroxine. And it correlates with short-term changes in protein energy malnutrition and recent changes in dietary intake. It has a shorter half-life, just 2 days. So that's why it tends to correlate better with protein energy malnutrition. However, it of course has its own shortcomings. Again, it's a negative response protein. And zinc deficiency can affect its synthesis. So you may actually have a zinc deficiency, not a protein energy malnutrition. And it decreases with hyperthyroidism. So that means too much thyroid hormone. And it increases with chronic renal insufficiency. So we also have retinol binding protein. You probably know this one because it binds vitamin A. It's synthesized in the liver and it's released with retinol. This is because retinol is powerful, so we need to keep it bound so that it doesn't just start acting all over the place. It's smaller for plasma protein. It doesn't pass through the renal glomerulus. It does correlate with protein energy malnutrition, but it loses its affinity for transthyretin with the release of retinol. It has a short half-life, just 12 hours, but again, it's a negative response protein. Retinol status can complicate its use, and renal patients may have elevated concentrations. And even though retinol binding protein is secreted from the liver according to retinol concentration, so anytime you see this notation, the brackets, that means concentration. So you can measure retinol binding protein mRNA, and that isn't related to retinol concentration. However, this is expensive. So now let's look at some serum proteins, like C-reactive protein. C-reactive protein is a positive phase protein, meaning it increases. And in fact, it increases within 4 to 6 hours of surgery or trauma. And it's an indicator of when to start what we call aggressive nutrition treatment. So we want to wait until C-reactive protein decreases to start therapy. Our aggressive nutrition treatment won't be helpful if C-reactive protein is high, because this is an indicator of inflammation. And we're going to get into this much, much more. So when CRP is decreasing, we're in the anabolic period. We can build. And this is often used in conjunction with transthyretin to indicate a person's protein energy malnutrition. So things that can decrease C-reactive protein levels are things that can decrease inflammation, namely NSAIDs. So these are things like Advil, ibuprofen, and aspirin. Statins and magnesium. People tend to have mild CRP elevations if they're female, elderly, if they have obesity, though this could be due to increased inflammation. Insomnia, depression, and diabetes. So you may be thinking to yourself, why do these proteins change with stress? Stress here is, we're not talking about psychological, we're mostly talking about physical. Although psychological stress at its extremes can also do this. With a physical stress, cytokines, or inflammatory markers, are released in response to the illness or trauma. These cytokines are signalers. They're messaging that we need to reorient hepatic synthesis of plasma proteins. And this is going to increase breakdown of muscle to meet the inflammatory response. So here we have tissue damage. We activate the cytokines. The cytokines tell the liver, help. So then the liver, along with the bone marrow and hypothalamus and pituitary, are going to start to make changes to deal with the stress. Need to fix this. So the liver will change the production of acute phase proteins in an effort to restore homeostasis and improve healing. The hypothalamus is going to increase production of glucocorticoids. This is also going to change the acute phase proteins. And the bone marrow is going to increase production of leukocytes. So to do this, the liver has to decrease gene expression and translation of some and increase gene expression of others. We also need to free up proteins to become positive acute phase proteins. So we need to increase catabolism, especially of muscle mass. We have a shift of water to the extravascular space, swelling. And a decreased amino acid availability. Why do you think we have a decreased amino acid availability? Because we have to do catabolism to create positive acute phase proteins. So now we're going to move into our serum enzymes and transaminases. These will be functional assays. Our first is alkaline phosphatase. This is an enzyme found in bone, liver, the placenta, and the intestines. And it's higher during pregnancy and in children during growth, which makes sense. Higher during pregnancy because it's really the only time you have a placenta. And then it's increased in the bone, which is rapidly increasing during growth. But elevated serum concentrations outside of pregnancy and adolescence can be associated with tissue damage or bone-specific damage, osteomalacia, but not osteoporosis, so osteomalacia, and increased bone turnover and or hyperparathyroidism. So if you recall, hyperparathyroidism, parathyroid hormone will increase bone turnover. So if we have high bone turnover, we're going to have high alkaline phosphatase. But low concentrations are not clinically significant. So this is only important if it's high. So just a reminder, we get parathyroid hormone from our parathyroid, which is next to the thyroid gland. When parathyroid hormone is low, it signals for bone calcium depositing. Bone calcium we get from serum calcium, so that means we are storing serum calcium. And that's going to decrease serum calcium. When it becomes too low, serum calcium, then the parathyroid gland will increase parathyroid hormone. Increased parathyroid hormone will increase osteoclasts. And osteoclasts break down bone. That will increase the concentration of calcium, which will be sensed by the thyroid to then again decrease parathyroid hormone. Remember, calcium is the most important for maintaining muscle contraction and nerve stimulation. So, although we think of calcium as being important for bone, this is actually second to muscle contraction and nerve stimulation. The muscle contraction and nerve stimulation is more important, which is why we have osteoclasts, which will release calcium from the bones. We also have creatinine kinase. This is sometimes called, oops, CK. This is found in all tissues except the liver, and it's elevated with cellular damage, especially skeletal muscle damage and myocardial damage. So high CK can indicate a myocardial infarction, severe muscle damage or trauma, severe muscle exertion, and muscular dystrophy. So CK is used to diagnose rhabdomyolysis, which is the rapid breakdown of skeletal muscle. Which can then lead to kidney failure because too much amino acids. We additionally have lactate dehydrogenase, which is found in skeletal muscle, the myocardium, liver, pancreas, spleen, and brain, and is also elevated with cellular damage, particularly after a myocardial infarction, hepatitis, kidney disease, burns, trauma, and strenuous exercise. Isoenzymes of lactate dehydrogenase will help determine the source.